Okay, today we are placing an epidural catheter. We have already checked the chart to assess that the patient has a normal platelet count, normal INR. There are no allergies. All of our consents are completed. There are no contraindications to epidural catheter placement, no infection at the site, no patient refusal, nothing like that. All questions have been answered. The preload crystalloid bolus is running right now to help mitigate any hypotension that could occur with the epidural. And we have our patient hooked up to a pulse ox and blood pressure cuff, both of which are on and audible. And if it was indicated, ECG monitor, fetal heart rate tones, all of that is done. We have an assistant in the room that's helping the patient get into the optimal position, hunched forward, back pushed out, kind of like a boiled shrimp. And we're going to go ahead and look for L4 and kind of get an idea of where we want to place this catheter. So I'm assessing her spine, and there's no, it appears to be straight, and I feel like there's an inner space here that is L3, L4, L4, L5, and I found the spot that I like and that I want to go. So at this point, we're going to open our catheter, or our catheter set, and we'll get her cleaned with chlorhexidine, and we're moving from inside to outside, getting nice big region clean, and we'll allow that to dry for 3 minutes. So I'll get my sterile gloves on. And I also assessed that the patient hasn't had any anticoagulation in the last 24 to 48 hours as well, so that has been done. No jewelry. We got our gloves on. Our hands were washed. Our protective eyewear and head covering are on. And we will get our drape placed sterilely. Normally I wouldn't have my sterile field kind of like covered by the drape, but I am a little bit short on space. So we're all dry from the CHG. We're going to just reassess and make sure that we have a good spot, that we know where we're going. I'm going to have the patient lean into me and leave a little marking with my fingernail just to make sure I know where I'm going to go. At this time, I'm going to go ahead and drop all of my medications. First, I will drop my syringe for loss of resistance with the sodium chloride, sterile sodium chloride, and put that to the side. Next, I'll drop my test dose. It'll be 3 cc's of lidocaine, and that is our 1% lidocaine. And then I will have our sorry, I don't know if I said test dose. That's our skin wheel numbing. And then in a 5 cc syringe, I'll drop 3 cc's of 1.5% Lido with 1 in 200,000 epi, and that is our test dose, a 3 ml test dose. So I'll have all my meds ready. I could also, with my assistant, go ahead and draw my bolus dosing, or I could just wait until I'm no longer sterile to do it. So if I wanted to do it sterile, I would just have the nurse hold the vial as I pull up 20 mils of 0.25% bupivacaine. So all that is ready. We'll go ahead and do our bleb with our 1% Lido. And before I do that, I'm just going to reconfirm. I can still see my thumb mark from where I like that inner space, and I'll do a nice little skin bleb there. And then I'm going to kind of go down and make sure that I'm in a place where I'm not hitting os, where I can feel a little bit of crunch from us passing the intraspinous process ligament. And yes, the needle holds strong, so it appears that we're in a ligament and that I've chosen a good spot where hopefully we won't hit any os as we advance. So at this point, we're nice and numb, and we'll go ahead and grab our 2E needle, going in the same spot that we already numbed. With our bevel up, I'm going to insert to about 3 centimeters. And at that point, I'm going to remove my stylet. I've already felt a little bit of crunch there from the intraspinatus ligament. And I will attach my saline-filled loss of resistance syringe and keeping it very still, attach it. And then I'm going to support my needle as I slowly advance farther, tapping, tapping, tapping. Feel a little bit more crunch as we pass through the ligament of flavum. And at 4 centimeters, I've lost resistance. So I'm going to stop there. I'm going to disconnect. I'm assessing to make sure no CSF comes out, that we didn't wet tap her, that there's no heme present. And at this point, we can go ahead and insert our epidural catheter. We're going to go 4 to 5 centimeters beyond the point in which we lost resistance. So if I lost resistance at 4 centimeters on the 2E needle, we're going to go to 8 to 9 centimeters on the epidural catheter. Normally, I wouldn't have my alligator clip on already, but it's stuck on, so that's that. So we're gonna insert, keeping control of our catheter. We're gonna go 4 to 5 centimeters beyond where we're marked on the 2E, so we're at around. I'm gonna go all the way to about 15 centimeters because I can pull back once I have my 2E out, but I can't insert it farther. So I'm at 15 centimeters. This time I'm gonna pull the 2E back and I'm gonna keep control of my catheter as I pull back. All right. Okay. Holding there, and then I can't get my 2E off obviously because I still have an alligator clip, so I'm gonna have to leave it there. All right, at this time, we're gonna go ahead and assess, making sure that we don't have any CSF or heme coming out. We're gonna attach our filter and give our test dose. It's 3 cc's of the Epi and 1% Lido, and I'm gonna aspirate first. Nothing, it looks good, and I will give my test dose. And I'm asking the patient, are you having any circumoral numbness? Do you have any ringing in your ears? I'm watching the vital signs, make sure the blood pressure or the heart rate doesn't increase significantly. And I'm going to wait 3 to 5 minutes before I give my actual bolus dose. But I am keeping an eye on those, and I'm going to go ahead and tape everything down per our hospital protocol. So this is nice and taped and secure. I'm going to have my little clip that it can clip to up here. And once 3 to 5 minutes have passed, we will go ahead and give our bolus dose, which is the 20 mils of the 0.25% bupivacaine. And if I wanted to add any Duromorph or anything to it as well. So that's going to be aspirate first and nothing, and we can inject. So we've bolused our catheter. We can go ahead and hook up to the PCA pump. We're going to get the patient comfortable and continue to assess vital signs, make sure our blood pressure doesn't drop, our heart rate doesn't increase, like that we're in a good spot and that our medication is going into the proper location. So we'll get her all taped down and continue to monitor. That's it.